All right, moving right along here to discuss hyper IgM syndrome. So hyper IgM syndrome actually makes a lot of sense. And the way to kind of just quickly get your mind around this is, remember, IgM is the only isotype of an immunoglobulin that does not require us to go through the class switching pathway. It helps you get to this pathology very quickly and the pathophys. Okay, so the classic defect is going to be the CD40 ligand receptor defect. So again, just going back to this here, in a healthy adult, we can see this T cell here, we see CD40 ligand, CD40, right? Remember, the CD40 ligand is usually going to be on the T cell, and the CD40 is usually going to be on the B cell. And so this is a co-receptor when we're going through activation of the B cell. By having that co-receptor there, we can get this patient to not only generate IgM antibodies, but also to generate IgG, IgA, IgE, IgD, right? So that's the concept. I need this CD40 ligand to undergo class switching. That's the point. Now, if I don't have that, then I have nothing for this B cell to bind to, and so I only make IgM because I can't get class switching. Remember, once that CD40 ligand binding occurs, the T cell can send over certain interleukins to determine what type of class switching we're going to undergo. But again, if I don't have this, right, I don't have class switching. That's the point. No CD40 ligand, no class switching. Now, I said before, how do I remember the different inheritance patterns here? Well, I don't remember anything that's autosomal recessive, but if something's X-linked recessive, X-linked dominant, or autosomal dominant, I want to know about it, right? So this is going to be one of those scenarios where you do want to remember that hyper IgM syndrome is X-linked recessive. And this is going to fit right into the category with things like severe combined immunodeficiency. If we're talking about a defective interleukin 2 receptor, that's also X-linked recessive, as well as Bruton's A-gamma globulinemia, which is also X-linked recessive. And childhood opportunistic affections, right? Opportunistic being infections we normally wouldn't expect to see. Right, pneumocystis is very classic, histoplasma, cryptosporidium. The other big one here that you want to remember is also going to be CMV. Okay, so these four are all going to be very classic in hyper IgM syndrome. But the biggest thing is when they show you the diagnostics, you're going to see the IgM levels can be high, normal, but all of your other immunoglobulins are going to be pretty much deficient. Okay, and again, how do you differentiate this from common variable immunodeficiency and Bruton X-linked A-gamma globulinemia? Well, again, you just look at the immunoglobulins. If all of the immunoglobulins are low, including IgM, well, then you're thinking more about a Bruton's or a combined variable immunodeficiency. But if the IgM is high or normal, now you're thinking more about a hyper IgM. The issue is just class switching. It's that CD40 ligand binding that we're concerned about. So I just brought this table back from the last slide. So just a couple things here. If I have a T cell deficiency, right? So if I knock out my T cells, again, we're thinking it could be SCID and it could be thymic aplasia, right? This would be very classic, particularly if I had both B and T cells knocked out. I definitely want to start to think about SCID. Now, what about if I just have B cells knocked out? If I just knock out B cells, I might be thinking combined variable immunodeficiency or Bruton's X-linked A-gamma globulinemia. Okay, so both of these would fall into this category. Now notice when I knock out this upstream, everything downstream is affected, right? Now on here, I just told you that if we have selective IgA deficiency, we would just be knocking out the IgA here. So the only thing we're primarily going to be getting, and it's not just to say Giardia, but Giardia is the big one, but the point is we don't have IgA, so we're going to get mucosal infections. We're not going to have issues with IgM, IgE, or IgG if we just knock out IgA. So this is going to be selective IgA deficiency. Okay, so selective IgA deficiency. Now, in hyper IgM syndrome, the issue is over here. It's class switching, right? So in hyper IgM syndrome, the issue is just class switching. So I don't have IgG, I don't have IgE, I don't have IgA, but I do have IgM. Because the issue is here, everything upstream should be okay, right? And so that's kind of how you got to think about this. You got to see how upstream is my lesion, so to speak, even though it's not a lesion, but how upstream is the defect from what's actually going on, okay? And that's how you can kind of make sense of this. Okay, the last two on here, not quite as high yield. Hyper IgE syndrome is sometimes gets confused with hyper IgM. In hyper IgE syndrome, sometimes called JOP syndrome, the issue is that we don't really have our T helper 17 cells. And remember, these cells are very much involved with getting neutrophils and macrophages to the site of chemotaxis. If we go back, initially when we talked about acute inflammation, we talked a lot about this. And the T helper 17 cells are very critical with that. So you do want to remember T helper 17 cells, and impaired neutrophil chemotaxis. And again, this is going to be one of those situations where if I don't have neutrophils, right, when we talked about acute inflammatory response, we need our neutrophils to help generate that response as well as our macrophages. And so if I can't get them to the site of the infection, we're going to have, walled off infections, abscesses, but we're not going to have inflammation because I can't get the neutrophils to the site of infection. This sounds kind of similar to what we talked about with leukocyte adhesion deficiency, where I couldn't get neutrophils to the site of infection because they couldn't adhere, they couldn't bind to the site. In this situation, I just can't kind of get the signal to them to get them over to the site of an infection or whatever it might be. But the point is we don't have inflammation here. Kind of similar to leukocyte adhesion deficiency in the sense that in that situation we didn't have pus, which is pretty much what we're talking about here. We can't get the neutrophils and the macrophages to the site of infection. And the way this is sometimes differentiated, and you can see there's other features here, coarse facies, eczema, but the way that you want to differentiate this is, again, you want to look at the labs. In leukocyte adhesion deficiency, we talked about some classic presentations, okay, and I won't go into all the details here, but there are certain markers that you're looking for, like CD18 in leukocyte adhesion deficiency. Here, the diagnostics you're looking for are elevated IgE and eosinophils, which are very classic for this hyper IgE syndrome. And you can also see very low levels of interferon gamma. Now, there's really only two major diseases where you're going to see low levels of interferon gamma. This is going to be one of them. The second big one is going to be interleukin 12 receptor deficiency. Okay, that's going to be the other classic pathology. But I think for the purposes of hyper IgE syndrome, that's really what you have to know. It looks kind of similar to a leukocyte adhesion deficiency in some ways, but the key is that you're going to have high levels of IgE, high levels of eosinophils, and again, because I can't get macrophages to the site of infection, those macrophages need to bind to T cells at some point when they present their antigens, and to get activated, those macrophages often will have binding that will lead to interleukin 12 and interferon gamma being released. If I don't have those macrophages getting to the site of infection because of impaired chemotaxis, I'm going to have lower levels, I would expect, of interferon gamma. Okay, and this is all, again, remember, because I have low T helper 17 cells. And why does this occur? This occurs because there's a STAT3 mutation. Now, STAT3 is one of those genes that's going to help regulate cell growth. Okay, and you don't need to really know any more than that. You do want to know that this is autosomal dominant. Remember, you want to remember the diseases that have the kind of more unusual inheritance patterns. So remember, hyper IgM, X-linked recessive, hyper IgE, autosomal dominant. Now, the last one on here is going to be Wiskott-Aldrich syndrome. This disease in particular, we'll talk more about when we talk about the hematology oncology, because it relates to that section in that there's an involvement of the platelets. But when we're talking about just comparing some of these different diseases, this one comes up because it can be easily confused for some of the other ones on here. So Wiskott-Aldrich syndrome classic mutation is the WASP mutation. Again, another X-linked recessive, a lot of very unusual inheritance patterns here, most of which, when in doubt, are X-linked recessive with a couple exceptions. This mutation is essentially causing some defect in the cytoskeleton. Okay, so you also want to remember that there's a defect in the cytoskeleton. Like I said, we'll talk about this in greater detail, probably in the hem-onc section. But because there's some defect in the cytoskeleton, when cells don't have the correct cytoskeleton and they try to kind of bind to each other to communicate, right? They have receptors here. But if the cytoskeleton isn't correct, right? If there's some defect in it, then when these cells try to communicate with each other, they're going to have some difficulty in doing so because the cytoskeleton isn't structured accordingly. So cell-to-cell interactions will be impaired. And the big thing that this calls our attention in immunology is impaired antigen presentation, right? We have so much communication between cells because we have to present antigens, right? We talked about that in pretty great detail. MHC1, MHC2, these are all used to present antigens. If I have impaired antigen presentation, now I'm going to have a really hard time generating immune responses. So these patients in general, because of the impaired antigen presentation, they'll classically have infections with encapsulated organisms, opportunistic infections, and a lot of this isn't really news compared to some of the other pathologies we talked about. This won't completely distinguish this disease for you. The thing that you really want to look for here is going to be the other classic findings here, and that's going to be eczema and purpura. Now, the purpura specifically is going to be classic classic because these patients have thrombocytopenia. This puts Wiskott-Aldrich syndrome in the category of these thrombocytopenic disorders like TTP, HUS, ITP, for example, and it makes you distinguish between them. If you're just thinking about this in immunology, if you have answer choices like the ones shown here, the way that you distinguish this is based on the thrombocytopenia though, because this is kind of the outlier. If you look at the immunoglobulins, the IgA and IgE will tend to be high, but the IgG and IgM will tend to be on the low side. So again, what I want you to focus on here when you're asked about Wiskott-Aldrich syndrome and they're giving you, immunoglobulin levels and that type of thing, look for the purpura and potentially the eczema, okay? And the purpura is because of the thrombocytopenia. These patients are going to be higher bleeding risk. And the low platelets can also cause things like epistaxis, for example. These patients might have recurrent nosebleeds, again, in the setting of this eczema and these recurrent infections. That's going to be very classic for Wiskott-Aldrich syndrome. And also notice here the platelets, not only do we have thrombocytopenia, meaning we have low levels of platelets, but the platelets are going to be unusually small. The whole point of that, again, is because I have these defects in the cytoskeleton. And one of the classic infections you'll also see here when we're talking about these recurring infections is these patients will tend to have recurrent otitis media. Okay, that's also very classic for these patients. Now again, if you just look at the immunoglobulins here, this is kind of the one situation where I would say the immunoglobulins are somewhat non-specific. They don't tell you a lot of information, but you usually do see an elevation in IgE and potentially IgA also in the setting of Wiskott-Aldrich syndrome.